This is the case of our patient with lower gastrointestinal bleeding. The patient's initial name is AP. She is 54 years old and a female, born on May 17, 1964 and living in Manila City. She is a Roman Catholic and a Filipino. Her dental chief complaint is nabasag yung pustiso ko nung nililinisan ko ito. Her medical chief complaint is may dugo na lumabas nung dumumi ako. The history of present illness for her medical chief complaint is that 8 years prior to consultation, the patient noticed that there was a blood in her feces. She didn't go to hospital for consultation. Few days prior to consultation, she noticed blood again on her feces. On the day of consultation, her lower abdomen is aching. In her gastrointestinal system, everything was negative except for the pain, which she rated 6/10. The history of present illness for her dental chief complaint is that 7 years prior to consultation, the patient went to dentist to extract her remaining teeth. She went back to have a porcelain denture. 3 years prior to consultation, she wants a new denture because the old one doesn't fit to her arch. 5 months prior to consultation, her lower denture fell while cleaning and it was divided into two. She used her old denture again. On the day of the consult, she wants to have a new denture because the denture that she is using has different colors. For the past dental history, at 47 years old, the patient became a dentulous. She went to a dentist to have a complete denture. For the past medical history, at 42 years old, she went into a surgery and had her ovaries removed due to presence of polyps on the left side. The patient is married with 4 children. She doesn't have a job. Her religion is Roman Catholic. She lives in Manila City with her family. Didn't smoke and drink alcoholic beverages, no illicit drug use, and no chronic NSAID use. For the family history of the patient, the father of the patient had history of hypertension. There is no family history of diabetes, PTB, cancer, kidney, and cardiac disease. Both parents are deceased. The father died due to hypertension and the mother died due to old age.
For the review of systems for our patient with lower GI bleeding, there was no complaint in weakness, fatigue, and fever. In skin, everything is also negative. There were no complaints in the head. Although she has a blurred vision, no complaint in ears, throat, neck, breast, cardiovascular, respiratory, urinary, genital, and peripheral vascular. Also, no complaints in joint pain, no depression and psychiatric or disorder, no complaint in hematologic and endocrine. And for the dental general appraisal, the patient is well awake and alert, well responsive and talks in an orderly manner, able to follow commands without any difficulty. She behaves properly. Patient is also well dressed for the weather and properly groomed. And for the medical general survey, the patient felt dizziness but is awake and responsive and behaves properly, and she was not in cardiorespiratory distress. For the vital signs, at the day of the consultation here in URM, her blood pressure is 120/90 mmHg with 73 beats per minute pulse rate and 18 beats per minute respiratory rate, and she had a normal temperature of 36.5 degrees Celsius. For the anthropometric measurements, the patient's weight is 65 kilograms with a height of 160 centimeters and 25.4 BMI, which is already in the category of overweight. For the physical examination, the dental physical examination shows that for the extraoral examination, for her extraoral, her face is symmetrical, there's no clicking sound and no pain or swelling in the DMJ, and there's no crack or fissures and ulcer in her lips. There was also no palpable lymph nodes and has a concave facial profile. For intraoral, she has a fair oral hygiene, color pink and firm gingiva. There are no present pathological conditions such as elevations. There were no elevations, fissure coats in the tongue, and it is in normal position. And then next is the Medical physical examination. This examination showed that the patient has no abnormal findings, so she was normal. And for the dental medical assessment, the patient is edentulous and has lower gastrointestinal bleeding secondary to bleeding internal hemorrhoids grade 3 with rule out diverticula. Next is the plan. For the dental diagnostic plan, oral examination will be done, and for the medical, according to the clerk's plan, the patient needs to undergo CPC and PC colonoscopy, and according to the resident, diagnostic plan should be deferred for now. For the dental non-pharmacologic treatment plan, there is a need for a fabrication of complete denture, and then for medical non-pharmacologic treatment plan, there is a need to increase oral fluid intake and increase intake of vegetables. Start psyllium fiber or Ipscus psyllium, 1 tablespoon in a glass of water taken 3 times a day with meals for 5 days. For the dental pharmacologic treatment plan, there is no need for any medication. And for the medical pharmacologic treatment plan, there's also no need for medication.
Our chosen journal is the etiological profile of patients presenting with lower gastrointestinal bleeding at Tertiary Care Hospital at Belagavi, a cross-sectional study. The background of the study is lower gastrointestinal bleeding is bleeding arising below the ligament of Thwaites. Hemorrhage from the lower gastrointestinal tract accounts for about 20% of all cases of acute GI bleeding. Lower GI bleeding is that which occurs from the colon, rectum, or anus, and presenting as either hematoxychia, which is a bright red blood or red wine color stools, or melena, blood streaking of the stool. The objective of this study was to evaluate the etiological profile of patients presenting with lower gastrointestinal bleeding. Their methodology is, this 1-year cross-sectional study was conducted in the Department of Medicine, Class Dr. Prabhakar Cork Hospital and Medical Research Center, Belagavi from January 2015 to December 2015. The study design was a cross-sectional study. This study was carried out from January 2015 to December 2015. Patients with lower gastrointestinal bleeding presenting at Department of Medicine and Department of Gastroenterology, Class Dr. Prabhakar Cork Hospital and Medical Research Center, Belagavi were studied. The result of the study was in the present study, majority of the patients were males with the male mean age was 43.82 and 17.96 years, and majority of the patients were married with moderate build and nourishment. As per the occupation, majority were housewives, followed by students. In the present study, diabetes mellitus was the most common medical history reported. Internal hemorrhoids was significantly associated with male sex, student's profession followed by housewife with mixed diet consumption. The clinical presentation significantly associated with internal hemorrhoids were hematoxychia, loss of appetite, tenesmus, passage of mucus in stools, constipation, abdominal pain, and vomiting. The conclusion is that internal hemorrhoids is the most common cause, followed by ulcerative colitis, though not common, carcinoma colon, solitary rectal ulcer syndrome, polyp, colonic diverticulosis, ischemic colitis, non-specific proctitis, and radiation proctitis are the other causes of LGIBT. Next is the relation of gastrointestinal disorder to dentistry. Digestive problems can take many forms ranging from acid reflux to constipation to irritable bowel syndrome. Common causes of digestive issues include not chewing food thoroughly and eating too quickly. The mouth plays an integral role in the digestive process as it's where physical and chemical digestive processes begin. That means the condition of your teeth and gums can have an impact on your digestive health. It's also interesting to note that gastrointestinal disorders can similarly affect your oral health. There are 3 gastrointestinal disorders that can have a negative effect on oral health. These are the gastroesophageal reflux disease or heartburn, inflammatory bowel disease, and peptic ulcers. Gastroesophageal reflux disease or heartburn causes acids from the stomach to enter the oral cavity, and these acids can erode tooth enamel. Some people often use antacid and bismuth products, which can lead to a harmless and temporary condition called the black hairy tongue. Good oral hygiene and stopping the consumption of antacids and bismuths can reverse the condition. Inflammatory bowel disease can manifest itself in the oral cavity, particularly in pediatric cases. Some oral signs and symptoms of IBD include mouth sores and infections, or bleeding or swollen gums. Prescription for IBD can also affect your dental health. Some common medication for Crohn's disease can cause dry mouth, gingivitis, and tongue inflammation. If you're suffering from peptic ulcers, it's important to note that some of the medications used to treat the condition have side effects that can adversely affect your dental health. You may experience dry mouth, black tongue, or a change in taste during the course of treatment. And for our expert opinion, GERD in correlation to dentistry shows in teeth with corrosion. Usually, the acid reflux makes the teeth corroded. There are two kinds, the internal and external. Internal will show in the lingual area of the teeth, while external will show on the labial side. That is according to Dr. Ainaj Sinagpulak.